Support for To The Point comes from Bausch & Lomb.
Beautiful and healthy looking eyes? It shouldn't be a compromise. Lumify Eye Illuminations, developed by the experts at Bausch & Lomb exclusively for the sensitive eye area. To cleanse, nourish, and brighten. Lumify Eye Illuminations, only in the eye care aisle.
As much as we've learned about ocular surface disease, there is still so much yet to be discovered. The good news is, this creates a world of opportunity for eye care providers.
The goal of this podcast is to better understand this chronic and complex condition and keep you up to date on the advances being made in its diagnosis and treatment. So let's get to the point. Welcome to another episode of the To The Point podcast. My name is Jackie Garlich, and I'm joined by my co-host, Jessilin Quint. Hi, Jessilin. How's it going? How's your week?
Hello, Jackie. Hello to all of our listeners. My week's been so good. Here in Maine, the weather is starting to become a little bit more crisp, and I am loving that. It feels like fall, which brings a new energy. So it's been a really good week. But speaking of Maine, we have somebody here as a guest that has some Maine connections, which I feel like never happens. So I am just over the moon excited for that. So we have Dr. Ed Jaccoma joining us. He is a board-certified ophthalmologist. He's recently returned to New Hampshire in the Portsmouth area, but he's spent nearly 30 years practicing in southern Maine. He received his medical degree from the University of Vermont, completed his internal medicine internship at the Washington Hospital Center, and did his residency in ophthalmology at the University of Virginia. He's had quite the career. He's taught medical students, resident physicians. He served as a medical director for various med spas. He's given probably thousands of hours of continuing education. He has a blog called iThera, and he's still in clinical practice where he's done cataract, different laser surgeries. But why he's here really has kind of fine-tuned the dry eye and aesthetic specialty. But one of my favorite things about Dr. Jaccoma is that he is so passionate about continuing to learn. And he always thinks outside the box. Like if you're ever in kind of a round table situation with him, he's the one that's like pushing that idea, outside the box into the next kind of higher level of thinking. And I just really appreciate that. So welcome, Dr. Jaccoma. We're so excited to have you here.
Yay, welcome.
Wow, my head is about 3 sizes bigger now. My hat doesn't fit anymore. Thank you for that introduction, and thanks for inviting me into your program. And happy to be here and to bring a little bit of my Maine connection to fellow Mainer.
I love it. And it's all true. It is, you are awesome. So you let that head be big.
We're maniacs. Okay, I get it. Okay.
So Dr. Jaccoma, you and I met at a dinner recently, and we were talking, as one does over a meal, about conjunctivochalasis. And I was so interested to hear how you are treating this in your clinic. And I think this is something that is often overlooked in our dry eye patients, and as a cause of contributing to their dry eye symptoms. And I think many of us are very familiar with treating conjunctivochalasis with, cautery or tissue excision. And what you are doing is something different from that. You're using radio frequency to treat a patient that has extra, conjunctival tissue. And I would love for you to talk a little bit more about how, I imagine you didn't always treat that with radio frequency. And I would love to hear how you sort of shifted and how you're treating that, and how you're using radio frequency to treat a patient with conjunctivochalasis.
Well, those are good questions. And I guess to think back to when I first became sort of more aware that there was even a thing such as conjunctivochalasis, that would give thanks and my hat off to BioTissue and Safer Seng, who originated this, I think maybe not originated, but certainly promoted the premise of mechanical dry, which is what happens when you don't have good oil. With more friction, you get this constant sort of back and forth over the surface of the eye. The cornea doesn't seem to care quite as much, but the conjunctiva by degree becomes sort of pulled, stretched, and becomes looser, partly through the mechanical friction, maybe also through some inflammation caused by that friction. And then the inflammation kind of gets down to the level of the deeper Tenon's conjunctival tissue, begins to disrupt some of the bonds that hold it together with the conjunctiva, and you start getting this kind of slippery rug that by degree shrinks the fornix because it rides up over the lower lid. And it's around that time that it starts to become a major detractor to the general circulation of the surface of our eye. I like to explain to my patients that tears are the lifeblood of the surface, that the best tear is water, salt, protein, and oil, that salad dressing like stuff is supposed to be replaced when you blink by the action of a blink, where the old dried up, used up, dirty tear goes down your nose, the fresh, healthy tear comes up from that little reservoir that we would just call the gutter between the lower lid and the eye. That little gutter, having the best tear that you have yet in your body, has yet to do any work. It is the freshest tear. You blink and there it is coming up to replace the old dried up, dirty tear. Well, if you have this membrane hanging over the edge of the lid, or even without kind of lapping over the lid, just becoming kind of like a washboard or wrinkles in that gutter, then the tear trying to crawl up over that washboard has a harder time. But if there's that little lap of membrane hanging up over the margin of the lid even a little bit, it will do several kind of bad things. The first is it becomes a gasket that prevents that tear from crawling easily out of that gutter. It also means that the surface of your eye is going to be draped in that old, used up, dirty tear, and that you're kind of constantly blinking that away. It also means that you're blinking on that membrane, which can be a little discomfort to the patient, and also might occasionally cause a subconjunctival hemorrhage, because now you have that sort of added mechanical pressure and the torsion and kind of additional twisting and other forces that happen on that membrane that could break those delicate blood vessels and cause those little hemorrhages. So it really does a lot of bad things that would only enhance the misery of the dry eye patient, because you're not turning over that fresh, healthy tear. So if, as I learned from Steve Safran, you could use radiofrequency to iron out those pleats, folds, and wrinkles, that seemed like kind of a natural prospect, because at the time I was also using radiofrequency, like I'll call it a customizable LipiFlow treatment, off-label. You can use it to heat and express waxy oils. So if you are being paid well by an insurance company to iron out those wrinkles and create a few little cauterized burns deep in that inferior fornix that will help to heal that membrane back in its natural position, so you now have kind of the fibrous tissue, scar-like thing that sets up, basically stitching without the stitching, you're now helping to anchor that membrane back where it belongs, and you've ironed out the wrinkles that would have been the washboard. And now it's not riding up over the margin of the lid anymore, so you don't have that gasket effect. And every time you blink, you're turning that stuff over. This is all the good stuff that comes out of that one thing. But then if you happen to put a shield in the eye, and we can get into my patented eye shield if you want, but that shield was developed pretty much around the prospect of putting that under the lid so that you could apply the heat and pressure over the lid with the same instrument, radiofrequency, that vibrationally will melt that waxy built up oil, backed up oil. Think of it like a cold hard stick of butter in your freezer that you take out and put in the microwave for a minute to make a puddle for that lobster dinner, speaking of Maine. And we then have a moment in time where that butter remains in a liquid state. So you now have the opportunity to massage it forcibly to squeeze it out of those backed up glands. And when you do that, you're now fixing the problem in essence that caused the problem. So if all you ever do is address the membrane, but you don't address what caused the problem, you're leaving a lot on the table for the patient in terms of ongoing evaporative dry eye disease, ongoing mechanical friction, all the bad stuff that happens, high osmolarity, all that kind of stuff that happens when you don't fix the oil problem. So, a simple tool used to fix two things at the same time, that by a side effect happens to also activate the fibroblasts that make and repair your collagen, so you lose a little bit of your dermatochalasis. So the women that come in complaining that when they put their lid liner on, that it kind of bleeds into that little extra fold of skin that hangs down over their lid, they can't see their lid liner, it gets in the way of their mascara, it hoods their lashes a little bit, so you get that lash ptosis thing. All of that can improve 1 to 2 millimeters with one single simple radiofrequency treatment in many patients. It isn't a knock it out of the park thing like blepharoplasty surgery would be, but it's more like the subtle, slight tightening and, redraping of that skin so that you end up with just a little bit less of that extra redundancy. So what's interesting is a lot of the patients will come back and they'll say, I think that helped, and I really want the other eye treated. But what about this? I mean, why does this eye that you didn't treat have all this extra skin hanging down? You're like, well, the eye that we treated had that too. But if we just hiked it up a little bit, that is what that treatment does. They're like, wait, so you did that with that thing? Okay, well then please do that for my other eye, because now I look kind of lopsided and I would like that to look the same. And then they're like, well, if it did that, could it also do this? And what about that? Meaning sort of tugging at their jowls and, saggy face and all the stuff that they do to recognize that one of the features of radiofrequency, one of the FDA approved applications, is simply to tighten skin in a non-invasive way. So I love the technology. I love that you can easily do so many different things with it. And another thing I will point out is that when you have somebody with a little punctal ectropion, that also adds to the misery because you're not turning over a tear as well as you could. But because while you're doing a chalasis plication, you can also, with the same little bit of anesthetic and a little bit of a more javelin-tipped probe on your radiofrequency, create a thing called ignipuncture, where underneath that area that is turning out, you apply a few little burns on the other side so it would want to, as it heal, pull it in. So you basically fix that punctal ectropion at the same time. That has the added benefit of making sure the tears go where they're supposed to now that they can come up out of that little gutter and start doing the right circulation for the surface of the eye. So it's just one little tweak that radiofrequency, kind of the Swiss Army knife of what I do, can do all these fun little things that can help a patient in so many little discrete, simple, but substantial ways.
So for patients who have gone through this, is it a repeatable procedure? Do you always do one eye at a time? What is kind of the post-procedure aftermath look like? Let's dive into all that.
Yeah, absolutely. So these are all great questions, the questions that most patients will ask me too. So the way that I tell them is that if at some point in your life you've had the misadventure of swallowing that too hot sip of coffee or eating that hot piece of pepperoni pizza and burning the inside of your mouth, that the mucosal lining of your mouth, not saying it in that way, but to the patient, you have this lining in your mouth, that lining gets burned. And that lining is the exact same lining as the lining of the surface of your eye. That white, that little clear membrane over the white part of your eye can be transposed. You can take one, buccal mucosa and switch it to the other and get a very good conjunctival graft that way because they are so close in what they are. So I make that analogy. I say, if you burn your mouth, you know what that feels like. It doesn't feel great. You also know that within about 3 to 5 days, you've already forgotten that you burned your mouth and you're back to eating hot pizza and drinking hot coffee because it feels fine, like it never happened. Well, typically when you do this, these tiny burns are of a similar nature. You will be a little sore for 3 to 5 days. During that time, you would probably not want to put a hot compress on your eye because it would be too hot. It already feels like you have a little burn. It will be a little irritated. There will be drops that you'll use called Toberdex. These drops have an antibiotic and steroid combination. The antibiotic prevents germs from getting a foothold in that little open sore that we create with that tiny burn, but also helps to heal a little bit of swelling, redness, and irritation that we just stirred up from that little burn. And over about 5 days, most people tell me, gee, that's not so bad anymore, but now my eye is still red. And I say, well, that's the way the eye heals. You'll always be red for about 2 to 3 weeks, during which time the eye can still be a little tender if you rub it hard. Don't rub it hard. You'll be using a tapering schedule of that Toberdex drop so that will gradually go away. And by the end of about 3 to 4 weeks, the eye is completely healed. Your oil glands are now starting to promote good oil. Your eye looks, feels, and often sees better because when you have dry disease, we all know that you lose some vision intermittently depending on how dry you are and how much SPK you have. And that you now have an eye that feeling that much better means you come back to my office about a month later to say, wow, doc, this eye is great, but what did you do to my other eye? Meaning we really didn't do anything to your other eye, but because we now made one eye so good, the other eye feels so bad, you now want to fix that other eye. The other question that you asked is one eye and then the other. That is the way that we do it, in part because just like with cataract surgery, there's always a tiny chance something goes wrong. Eye might take a little longer to heal. It might have some other problem, infection, something. You'd rather have it in one eye than both eyes. And I have had a couple of complications, which I'll share with you now because that'll be your next question. And the complications are always the person who doesn't listen and goes from what we just did to someplace where they get dirt or germs or chemicals or something bad in their eye. So I had one woman who was a housekeeper and house cleaner, went from my chair to clean somebody's house, got dirt in her eye, ended up with an infection in her eye, came back to the office. We saw that it was an infection, cultured, treated, got all better. And then she got so much better, she said, okay, now fix my other eye and I won't go do that stupid thing again. Then the next time this happened was a guy about my age who had this thing treated in one eye. The next day, not the same day, but the next day, went down into a cellar, moved all the wood from one side of the cellar to the other side of the cellar, got mold, dust, dirt, whatever in his eye, became infected. We treated it, got better. He decided not to do the other eye because he was afraid he would do something stupid like that again. And it was kind of a scary thing for him, and I can understand that. Since then, I have been extremely forceful about telling patients, do not go stick your head in a dirty place for at least 5 days. That means not like turning over your garden. It means not like doing all your spring or fall cleaning. It means not like running a vacuum cleaner that blows dust and dirt and smelly stuff in the air. All the kinds of things that you can think of that you would rather not expose yourself to, like whatever, don't do it. Like, stay away from that stuff for 5 days. You'll be okay. And I think of it a little bit like cataract surgery, only fortunately this is not an intraocular thing. So you're not exposing the inside of the eye to that kind of infection unless they happen to have a thin-walled bleb or something, and then that's a different story. So the bottom line is, I think it is extraordinarily safe that way. The third is a very interesting patient who is in her mid-40s, who was a flight attendant and was flying back and forth from the East Coast to the West Coast at about 30,000 feet. And at that level, there is very little moisture in the air, and she was having the devil of a time with her dry eye problems. So she had had all the common stuff that we do, the BLEFX, the RF, meaning just a heated massage, IPL treatments, Restasis, you name it, pretty much everything I could throw at her. And she got very much better, but still was struggling at that high elevation, was still feeling like she needed something more done. And in her mid-40s, she had just enough conjunctivochalasis. So I said, well, we could do that. I think that could be a good thing because it'll help you to turn over your tears better. It gives me one more chance to heat massage these glands. Insurance will pay for it. And then her face brightens up. She's like, oh, insurance will pay for it. Okay, well then let's do this thing. So we did it. And the problem that I ran into is that it just did not want to heal. Like, weeks go by and the eye still looks red, angry, uncomfortable. She's missing some of her work now. She's not happy. So I reach out to my colleagues, including, the guy who kind of trained me on the idea of doing RF for conjunctivochalasis. And everybody's like, no, it always gets better. Just give it more steroids, a little more time. These are dry patients. They're complicated. They have bad surface. Things take longer to heal. Don't worry about it. It'll get better. So I continued to push and steroids. And another few weeks goes by and she's like, I am fed up. I can't live with this. This thing is driving me crazy. What else have you got? So I referred her down the street, because I was in Maine at the time, to the fellow who is the ultimate guru of all things with weird conjunctiva. And that was Steve Foster at the Mercy Eye Institute. So he writes books about this stuff, has published more on weird conjunctival things than anybody. And the thing that occurred to me is, what if it's like ocular cicatricial pemphigoid or some other really peculiar, weird thing? I could miss that, and it would just only make things worse. Could be something like that. Let's send her there. And she's like, fine. Goes down, sees him. He looks her over, takes a great big chop of this conjunctiva off, puts it into his lab, comes back with an undifferentiated autoimmune disorder. Like, he couldn't even tell what it was. It was some autoimmune thing. And said, she needs systemic anti-inflammatory treatment, immunomodulatory stuff, puts her on all kinds of everything. She gets better. Fortunately for me, decided not to do the other eye. And I think fortunately for her too, but the bottom line is she got much better. And I think that was the final turning point. So the concern that I would have and still have to this day is, how could I have avoided that? Like, how would I have known without doing a conjunctival biopsy? This is a pretty run-of-the-mill, to me, fairly average dry patient who just was only getting partial and not fully better. And then we did our thing and it just didn't go well. So at this point, I still like to tell most of my conjunctivochalasis patients that story in a nutshell, with the understanding that if you're walking in the woods and you come across some old tree lying on its side, and you wonder what's under that tree. You give it a good kick and it kind of rolls aside and you find all kinds of weird things crawling out. You would have never known that that stuff was there without kicking that tree over. And so the issue then is sometimes you just have to kick the tree over to see what's going on. And I think that was that case. So maybe it was the best thing that could have happened because it brought it to our attention sooner in a way that was able to get her appropriate levels of care. And since then, I've been even a little more cautious. But what else do? You move the conj around. Does it have, subconjunctival fibrosis? Oh, maybe it could be OCP. But then the other side of that is people who've been on chronic medications for glaucoma or using preserved artificial tears will often have the same problem. And it's not OCP. It's just too many benzalkonium chlorides or something, right? So there are lots of things that can masquerade. And I think you just have to, at the end of the day, accept the fact that every once in a while you are going to kick that tree over and find a weird thing under there. And now you just have to deal with it. So that's pretty much the gamut of my weird stuff. And that's after treating thousands of these things. So it's not like they happen every day, but they certainly can happen.
This episode of To The Point is sponsored by Tarsus. Tarsus Pharmaceuticals applies proven science and new technology to revolutionize treatment for patients, starting with eye care. Tarsus is advancing its pipeline to address several diseases with high unmet need across a range of therapeutic categories, including eye care, dermatology, and infectious disease prevention. Tarsus is proud to announce that Xdemvy, lotilaner ophthalmic solution 0.25%, is FDA approved and available to prescribe.
I'm so glad you shared that story. I mean, not everything is a win instantly. So I think sometimes we oftentimes are always just telling the story of the patient that did so much better and is so grateful to us. And that really isn't the case. So I really appreciate you being honest about, a case that didn't go well for you. I think if we could even step back even a little bit on how do you decide what is too much conjunctivochalasis? So sometimes you'll see it, and there's many offensive things that this dry eye patient might have. MGD, they've got blepharitis, they've got this, they've got that. Yes, there's a little conjunctivochalasis. Generally this isn't the first thing that we're going to go for, like, oh, let's refer for some excision, or in your case, radiofrequency. There's no real grading scale that I'm aware of on how much is too much. We've got it for MG atrophy, but what are we doing, and how do you decide on how much is too much? How do you rule out what's the most offensive thing for that patient?
So that's a great question. And there is a grading scale for conjunctivochalasis, this lift-off scale, where the lid parallel folds are what you measure. And so you count like the number of lid parallel folds. And if it's only one fold, then it's 1 plus. And if it's 2 folds, it's 2 plus. And if it's 3 folds, it's 3 plus. And that's kind of where the system normally cuts off. But I've added a fourth, okay, which is when it literally is hanging over the edge of the lid. So, that's kind of the super version of what conjunctivochalasis is. What's interesting is that there are some patients with 4 plus conjunctivochalasis running around with absolutely no signs or symptoms, meaning they don't really have any SPK, they don't really have any dry eye symptoms, they don't seem to have any real problem. And you have to wonder, how does that happen? Okay, I guess these are just exceptional people. Well, maybe not. Maybe there's some other fairly common, simple explanations for that kind of thing. The first that I would consider is that when the conjunctiva is that loose, it has this great tendency to seal the puncti to a degree. In other words, they kind of get sucked into the punctum or roll over the punctum, which in essence is a punctal plug. So if somebody has a degree of dry eye disease but happens to have intrinsic punctal plugging, then they would get better, kind of the way a punctal plug might help them if that's their better answer. Not always, but just the idea that there could be such a thing. Second is the very common thing that I think we all see, which are patients who just get used to stuff. They don't really complain because that's their normal baseline. They're not really complaining type of people. They would probably, walk in on 3 crutches and tell you, oh, life is good and I'm happy and everything's great. Very different than the Eeyores that come in who look great and say, I can't stand my life anymore. So, there's that spectrum of people. And the idea that sometimes you will find degrees of this problem that is impactful to the patient's overall eye health, but they don't want to deal with it, I don't really twist their arm. I kind of feel like I would rather not fix somebody who's truly happy and has zero symptoms, partly because insurance would not like to pay for that, but partly because if there is a complication, they're going to look back at me and say, wait a minute, why did you make me do that thing? Because I was fine before and now I'm miserable. So, I think you have to keep that in the spectrum of how you look at this kind of stuff. But to the next level, there are people where even with a moderate to relatively mild, what you or I might not consider a high level of conjunctival chalasis, I think sometimes it can also be impactful to their problem, because when you consider the dynamics of how a tear gets moved across the eye, and these are people who commonly have a substantial amount of trouble anyway, it's like one more straw on the camel's back. It's like one more thing. And if you take that straw off, it just takes that little extra weight off their shoulders, makes them a little bit more comfortable, helps a little bit with their dynamics, and gives you that one-time chance to unclog some more oil glands, which I think is generally a positive thing. Some people don't realize until it's done what they were missing. So I think that's another piece of that.
A few other ways to kind of address the conj that I know a couple of our just colleagues are using are plasma pins. And I know you're very much into aesthetics, and plasma pins are, used in the world of aesthetics for different skin tightening. Have you dabbled in that? What's your experience? What's
Yeah.
your opinion?
So I do have a plasma pen, and it is one of the newest of the variety that are available out there. It is a direct current version of this thing called the Jet Plasma 2. I apparently was the first ophthalmologist, or maybe the first person in all of the United States to get this thing, because it's a pretty new thing. And fortunately, some of the colleagues that I'd helped to introduce to radio frequency in Canada were kind enough to kind of steer me early in the course of this into, gee, you should have this thing. So I listened to them because they had listened to me, and they sounded pretty strong about this. So I did get it. And plasma is a very interesting thing. So I don't know how much you know about plasma. I'm certainly not a physicist. But the interesting thing about plasma is that it is the fourth state of matter. So what is the states of matter? Well, you've got solids, which are these little molecules just kind of sitting there. You've got liquids, where you may have heated that solid to where all those little molecules are vibrating around. They start to kind of layer out and become that liquid thing. You heat them further, they turn into a gas. Now you got all these molecules in the air. But then you add more energy to that system. And so you now have an ionized system where electrical charges can move through that system. And that's plasma. So that is what actually fuels our sun. It is what is like, think of it like a lightning bolt. These are different versions of plasma that are common things that we all see every day, but don't really think about. But when you take it to the more microscopic level, the beauty of plasma is that you can very selectively create little electron flows that can get into cells, creating tiny channels or ion channels that is called electroporation. So electroporation is one new word we can introduce, where you are, in essence, creating little pores in tiny cells caused by electrical currents. And when you do that, depending on the rate at which you apply and how much energy you apply and how many pores you apply to that cell, will allow it to either become more energized and do its job better, or to literally die and go away. So you have think of it like a range starting from 0 to cell death, with the ability through the tuning and the tip that you use. So you can use silver tips, gold tips, things that allow extra electrons to move faster and more easily, will hype up the kind of plasma charge that you get and how much you can do. So energy, the system that you use, the tip that you use, direct current, which is different than alternating current, which has another unique property of being more unidirectional. All these things begin to become the science, and therefore the medical science, of how you can deal with the stuff. So what do you do when you do that for conjunctival chalasis? Well, you create little spots of burns or little spots of energy that could be anything from just a little extra activation of those cells up to a complete burned hole in that membrane. If you use the tips that are commonly used for that at the energies that are commonly used for that, you get little burns, and they look like little polka dots, and you can apply them as many and as close as you need to get that tightening effect. In my world, I think, prefer radio frequency in the way that I do it, because it's a light searing that I can use a little angled forceps to quickly make a pass and create a very fine searing effect in that membrane. And then I can gather another fold to do the same thing, and another fold to do the same thing. And in just minutes, I can have accomplished a great treatment, versus selectively little tiny lightning bolts all over the lower half of the eye to try and get a similar effect. I don't think that there's any real safety issue, because as soon as the electron hits the conductive tissue of your eye, it kind of gets diffused into that. So it's not like you're sending lightning bolts through the wall of the eye into the retina or other parts of the eye. So it is, I think, a very safe way to treat it. It's just a little more time consuming, a little bit more finesse, and maybe a little bit more art to that treatment, as opposed to in my world and in my hands, quicker, simpler, until I learn more. And I'm still kind of learning about this whole plasma thing. I have been using it for a very good desquamation of the lid margin, and for what we could call blepharitis treatment, or for uncapping the meibomian glands when they become kind of heavily capped. Because if you use it at the right energy, you'll literally just slop off those layers of cells very sequentially, very easily, down to the sort of more basal layer where the meibomian gland orifices would be more open and available. In addition, if you treat over the conjunctival palpebral surface, there is some thought that these same electroporation effects can get to the level of the meibomian glands and perhaps stimulate them in a way that makes them more active. It also has a very interesting kind of TENS-like effect. When you apply it over muscle, the muscles will contract because of this electrical current. And so the contraction of the lid while you're treating it probably also helps to propel some of the meibum out of these glands, because you're at the same time a little bit of heat, at the same time a little bit of stimulation, at the same time the contraction of the muscle, kind of a very natural way of wanting to move meibum. So I think there's a lot of good things that can happen with plasma. I am still, I think, kind of in the first couple of months phase of learning the fuller range of how it would work in my hands. And I think if somebody didn't have radio frequency and wanted to use it as a starter tool, that there are a lot of good things you can do with it, because you can literally do surgery with it if you want. But you can also do this more selective kind of electroporation thing, which I think has some added value.
That's so interesting. I just learned a lot about plasma pens. I don't know about you, Jessilin. I was not so familiar with this. So I thank you for telling us all that.
Sure.
I have one kind of final question that I want to ask you in terms of what do you think, what is one of your biggest tips that you have found in managing all of the dry eye patients that you have seen? What is one of your big take home you have for listeners?
Well, that's a great question too. So I think the biggest thing is to try and get the big picture and understand the fuller range of what's causing the patient their problems. Because a lot of times it's sort of a multifaceted, somewhat compounded problem that you have to literally kind of pull apart and treat each part individually to get the fullest benefit. If your problem was only obstructed meibomian glands, then a simple pass with any heated massage might take care of that problem. But most of the time, it's not just that. Usually there's a degree of blepharitis associated with that, because you've got stagnant meibum that is now kind of a buffet table for little germs to hang out and do their thing and create, their little happy plaque-like, glycoprotein thing that we call scurp, but you could call plaque like on your teeth. And then you get further inflammation because your body's natural defense system is like, holy cow, there's germs out there. Let's go get them. And you start sending in all your napalm hand grenades and bazookas in the way of your cytokines, chemokines, antibodies, whatever. that stuff is now pouring onto the surface of the eye, which starts to beat up on the aqueous producing glands or cells that now start to shut down, and now they're not working. And now you get an element of aqueous tear deficiency on top of your meibomian gland dysfunction, on top of your blepharitis. And then you've got this frictional thing going on, and now you're getting more and more conjunctivochalasis. I mean, you can see how this thing just kind of continues and spools out. And so if you jump in and do any one thing, and that's all you treat, you're going to leave a lot on the table, a patient who's only partially treated, not very happy. So I think you really have to look at the whole picture. And I usually start with aqueous tear deficiency because I am very old school, and I still like a anesthetic Schirmer's. And if I find that the numbers are 10 or more, I figure aqueous tear deficiency is not their major issue. If the numbers are 6 to 10, then there is a substantial amount of that. And if it's less than 6, there's a huge amount of that. And, maybe when they get down to 0s, 1s, and 2s, we start thinking about things like Sjogren's syndrome or other autoimmune issues. So I always try to address that kind of upfront first because, one, it's not as common as some of the other stuff, but if you miss it, it's leaving a big chunk on the table. And the way that I usually deal with that is make sure they're drinking enough water, add anti-inflammatory drops according to the level of what I think is the level of their inflammation. Ultimately maybe punctal plugging or other things. So there's a range of things that we can do. The next step for me is to look at meibomian gland dysfunction and to try to figure out how much of it is primary inflammatory rosacea-like stuff where the oil coming out, and it does come out, looks thin, clear, but is obviously full of some inflammatory stuff. They have these red eyes, they're not happy. And so I would call that an inflammatory MGD versus an obstructive MGD, where you can still have elements of inflammation, but with obstruction, you press on the glands and you don't get stuff out. So the only way to make that distinction is to press on the glands and see what comes out. You can image the glands and see what they look like, but at the end of the day, if you don't see what the oil looks like, you're missing something. And then you can look for foam in the oil because now you know that you've got lipase-bearing bacteria eating that stuff, and there's another element of blepharitis and inflammation. So that's like the next step. And then I look at how do we deal with that? Well, if it's more the rosacea inflammatory, think about IPL, think about oral antibiotics, think about dealing with blepharitis, blah, blah, blah. And if it's more the obstruction, you got to clear the obstruction. If you don't clear it, anything else that you do is just the Band-Aid effect that is buying time, kicking the can down the road, letting their MGD get worse without really fixing it. So I think that's a major one. And then you can look at all the other co-contributors. So there's a bazillion of them. Do they have nocturnal lagophthalmos? Do they have true lagophthalmos? Is there some, ectropion, entropion, trichiasis? Is there allergy, which is a big one? On and on. So we can go on forever about that stuff, but I think it is really important to get that big picture, introduce the patient to the concept of the big picture. So the thing that I've done is I've created a multi-page handout where I include little blurbs about each of these things, and then I put their numbers in there. So your aqueous tear deficiency is bad because your Schirmer's were 4 and 3. Your MGD is bad because your tear breakup time was 1 and 2. Your tear osmolarity is like 350 and 380. There's things that they can relate to that gives you that cheerleader function down the road to say, hey, look, your aqueous tear is better because your Schirmer's went from 3 and 4 to 9 and 10. We're getting there, or gosh, your tear osmolarity was so high. Now we can measure it. It's much better. And your tear breakup time was 1 and 2, and now it's like 9 and 10. So this is how you kind of get the buy-in from the patient, even as they continue to struggle and feel like they're not all the way there. But, you can keep kind of leading them and helping them know that you're helping them. So that is, I think, a big part of what we do. I could go on, but I'll shut up.
I love that. I think you hit the nail on the head. Hearing, dry eye can be very complex, right? There's all these different layers, and it's not an overnight. So hearing your thought process on that is very, very insightful. But this wouldn't be a To The Point episode if we didn't at least ask you what your life lens was or is. So do you have a life lens, something that's changed the game in a positive way that's been impactful for you?
So my life lens, I would say, is I'll call it the art of listening. Because when you think about it, the way that you learn is not by assuming and jumping in and doing things. It's by listening to your patient or to a nice music or to your dog barking or whatever it is. But, that's a sense that I think too many of us tend to tune out. We're so listening to, noise rather than like good stuff. So I think podcasts like this are not noise. They're good stuff. But I also think that when you get right down to it, just being a good listener helps you to interact with people better, to understand them better, to have a fuller life, because music is a great part of that too. Just all the things that come from being a good, observer with your ears, observer even with your eyes. But, if you're going to single out one thing, I'll just pick the ears. Fortunately, I still can hear, even if I'm a little hard of hearing. And maybe I've used my ears too much.
I love that life lens. That is perfect. That is a good life lesson for all of us to listen more and talk less. So thank you.
Okay, well, thanks for the time with
Yes.
your crew here. It's been
If
fun.
listeners wanted to follow up with you or had a question after listening to this episode, what's the best way that they can contact you?
Well, fortunately, my iThera.com is an active website where practitioners can jump in to ask about some of the technology, like particularly these shields that we make, but also can ask questions that, they just send in info@ithera.com. Gee, I'm a practitioner. I have this question for Dr. Jaccoma, and they will bounce it to me. You can always reach out directly to me through my offices. So I have an office in Sonoma, Mass. I have an office in Portsmouth, New Hampshire. I am very open to trying to help practitioners with anything I can. And then, trying to connect with me and the patients. If they go through the same portal, they can reach out through the ithera.com thing. They can also call my office. But if they go on the blog, there is a search bar. And so I will hype this because fortunately, we were able to create kind of an index through the search bar where if you type anything into the search bar that I've ever said, done, or otherwise commented on, it will pop up with a stream of all the things that I've ever touched on about that. So if you just put in CCH, you'll see a huge list of all the things that have at one time or another talked about CCH. If you put in, something on like Lacrophil, it's my new favorite filler. You can jump in and learn about Lacrophil. I will have, I think, segments coming up soon on the plasma. I have not spent as much time talking about RF, in part because it's not on label for dry eye disease. So it's a little bit of a gray area as to how much I can promote or, otherwise advertise about that kind of stuff. But I think it is important for patients to be able to have a good resource online because too many online sources are not that great. And so I try to make mine pretty clinical, but at the same time, very patient level. So anybody who reads this stuff won't be getting the dry dissertation from a textbook. It's more like, here's my take on it, and at a patient level.
It's a great blog, and it's EYETHERA.com, for all the listeners. It's a great resource. Well, thank you, Dr. Jaccoma, for being here. It's always a pleasure to talk shop with you, and I learn something every time. It's so great.
Well,
I
I
learned
appreciate
so much.
that.
I learned a ton on this podcast. So I know I'm going to go back and re-listen to this.
Well, reach out again if you have more questions or if I can help with other things. It's true that I love RF. That is my true focus for the most part, but I happen to have a lot of other tools in my toolbox and a lot of other things that I also like to talk about. So happy to jump in anytime for anything that I can help you with.
Yeah. Thank you so much again for taking the time.
Absolutely.